Uh, Great. We are now going to transition to a case-based discussion of perinatal HIV prevention and treatment, and we've got a great panel here today. The moderating the panel is Dr. Susan Cu-Uvin, who is a professor of obstetrics and gynecology and of medicine at the School of Medicine at Brown University. We have Allison Agwu joining us back again. We have Dionne-Odom from UAB and Ron Wilcox from HRSA. So I'll turn it over to you, Susan.
Can you see my screen?
Yes, we can see it. It's not in presentation mode, but we can see your slide. There it is. Yes.
Okay. Well, I want to thank the organizers for inviting me to give this case-based discussion on perinatal HIV care and prevention. And I'm very happy to have my wonderful colleagues in the panel who will be helping all of us out. People seem to forget that one of the major successes in ending the HIV epidemic is in our success in preventing perinatal transmission. Without any antiretroviral therapy, there's 25% mother-to-child transmission. With antiretroviral therapy, in the United States and in Western Europe, we are less than 1%. So we have achieved a lot. And even in some low and middle income countries, the rates have gone down to 4%. So I think that we should not forget that if we're looking about ending the HIV epidemic, perinatal transmission is one of the areas where we have done a lot. I receive royalties from UpToDate. That's my only disclosure. And my goal is that after this, you will be able to select recommended antiretroviral therapy for women planning to get pregnant and during pregnancy. Initiate treatment for acute HIV infection during pregnancy. Initiate pre-exposure prophylaxis to prevent HIV transmission during pregnancy. And describe HIV infection and breastfeeding related issues, which is becoming one of the bigger topics. Now, this case presentations will have a polling feature. So I will discuss the first case, and then I will give you options for answers, and then you will be polled. And once the polling is done, we will be able to share with you what the audience thinks would be the best answer. So let's start with case one. She's a 28-year-old gravida 1 para-0 with newly diagnosed HIV infection discovered during prenatal visit. She's 10 weeks age of gestation by ultrasound dating. She is asymptomatic. Her initial CD4 count is 300 cells per cubic millimeter, and her HIV viral load RNA is 300,000. The other labs are all normal. She has no other comorbidities, and she's awaiting her HLA-B5701 result. So here are the choices for what regimen would you like to start her with? 1, dolutegravir, abacavir, FTC. 2, dolutegravir, tenofovir, FTC. 3, efavirenz, tenofovir, FTC. 4, rilpivirine, tenofovir, FTC. 5, bictegravir, TAF, and FTC. I think we have our answers. And most of you chose dolutegravir, tenofovir, and FTC, which is what I would like to choose. Let's move ahead. This is a two-part question, and then we will ask the panel to discuss with us why these were the answers that we chose. So the answer for this one would be dolutegravir, tenofovir, and FTC. Oh, what happened to my screen? It's not moving. I'm frozen. What should I do? Okay. Which antiretrovirals are not currently recommended for pregnancy? 1, bictegravir, tenofovir with FTC. 2, dolutegravir, abacavir with FTC. 3, darunavir, cobicistat combination with NRTIs. 4, atazanavir cobicistat with combination NRTIs. Or 5, numbers 1, 3, and 4. So please start putting in your answers. So again, this is a very, very well-informed audience. And most of you answered numbers 1, 3, and 4, which is the bictegravir, the darunavir boosted, and atazanavir boosted regimens with NRTI combinations. So why don't we see what the answers, how we answered this, and maybe we can engage our panel to see about their thoughts with the answers to questions 1 and 2. Anybody in our panel who wants to start?
Can you go back to the question 1? Just want to go back and see what the options were. Sorry. Yeah.
So remember, this is the Gravida 1, newly diagnosed, CD4 count 300, viral load detectable, and this would be her first regimen at 10 weeks of pregnancy.
So I can jump in first. I certainly agreed with the audience. The dolutegravir TEF-FTC, we have data based on that in pregnant women. I think from the impact study, I think actually looked at this regimen in pregnant women. We don't have the data on BIC-TAF-FTC. I think that's going to be studied in the new protocol 2026 that's coming through. She's newly diagnosed. We don't want to wait for the HLA-B 5701. So would go ahead and start something else that we need to. And then I don't think a reason to initiate efavirenz or rilpivirine, I would not necessarily use those as preferred.
Ronald?
I think the only thing I would add to that is the rilpivirine with the high viral load would be kind of contraindicated because the viral load is over 100,000. So
300,000. So Jodie, anything?
No, I totally agree. I mean, and this audience, again, is very savvy and works with this stuff probably regularly. I sort of find that most providers who don't take care of pregnant patients fall in 2 camps. They're either very scared of pregnant patients, they want to give them no medicine and I'll pass off all the care to someone else. Or they say, let's just keep them on what they're on. I don't want to make any changes. They're doing great. So I think there is a good opportunity for us to work with our colleagues and explain the data. And a lot of this is driven by the fact that we just don't have the pregnancy studies that we would like, often for a decade or even 2 decades in our HIV medicines. So it's really great. Exactly. I was just going to say, it's really great to have things like VESTED and have impact to increase our database. It makes all the difference when we can talk about studies with our colleagues. So I fully agree with the panel and the audience.
And the audience is also extremely savvy when they chose number 5. What would you not recommend is bictegravir, because we don't have enough data. It has insufficient data, although hopefully we will reach the point where we might be able to use it. And the cobicistat boosted regimens are not recommended. You could use also alternative, the ritonavir boosted regimens. But let me just share with the audience the recommendations or preferred initial regimens in pregnancy. The NRTI backbone of abacavir 3TC, if you have HLA-B5701 that is negative, and unfortunately for many clinics, it will take 1 or 2 weeks and you want to start ahead. Tenofovir FTC or tenofovir 3TC, looking at potential renal toxicity. And among the integrase inhibitors, dolutegravir, abacavir 3TC, again with caveat on HLA-B5701, dolutegravir plus a preferred dual NRTR backbone, raltegravir plus a preferred dual NRTR backbone. And for the protease inhibitors, the atazanavir, ritonavir plus your NRTI backbone, or darunavir plus a preferred dual NRTI backbone. And our audience really shows the dolutegravir with the preferred dual NRTR backbone, which is wonderful. But what were our initial fears about dolutegravir? I think if you remember the Chipama study, which was done in Botswana, the initial findings were for women who were on dolutegravir at conception, the rates of neural tube defects was at 0.94%. And you could see that with non-dolutegravir or efavirenz containing regimen, or dolutegravir taken during pregnancy but not during conception, didn't make much difference between the HIV negatives. But however, as the study accumulated, this rate really came down to 0.3. So right now, the current recommendation of the perinatal guidelines is, although there is a slight increase, I think that even women planning to conceive can take dolutegravir when the risks are explained to them and shared decision making. So it's now a preferred even for women trying to conceive. And there's really no problem when they are taking it during pregnancy or initiated during pregnancy. So anything the panel wants to say about this slide?
I think you said it all.
Okay. Well, then let's go to case number 2. We have a 35-year-old person living with HIV. She's gravid at 3 prior to. She had a negative HIV test at her first trimester visit. She went to visit her spouse and family in Zambia during her pregnancy. Her obstetrician considered her high risk of acquiring HIV and did a 3rd trimester HIV testing when at 34 weeks age of gestation, when she resumed her prenatal care here in the US. It's unfortunate that she has seroconverted and is now HIV positive. Her CD4 count is 100 cells per microliter, and her plasma viral load is now 400,000 per cubic milliliter. Very much an acute seroconversion scenario. She's asymptomatic and all her other labs are normal. Again, HLA-B5701 testing results are going to take 2 weeks. HIV genotyping was set. So we're going to poll the audience again. What is the best decision for this patient? 1, wait for HIV genotypic testing results before starting antiretroviral therapy. 2, wait for HLA-B5701 results because abacavir is recommended treatment for pregnant patients. 3, start antiretroviral treatment immediately to attain rapid viral suppression with dolutegravir, tenofovir, and FTC, and start PJP prophylaxis. 4, start antiretroviral therapy immediately, but she does not need PJP prophylaxis. Like I said, I can't say anything about this audience. They chose number 3, which is to start antiretroviral treatment immediately and to start PJP prophylaxis. Almost all of you answered. So thank you very much, because I think that is what I would do. And let's ask the panel to share with us their thoughts on this issue and how they feel about the answers.
Like I always talk first. I have to try to hold back.
Go ahead, Dr. Agwu.
No, I'm yielding, Dr. Dionne. Go ahead.
I mean, to me, this is a case that screams out for an integrase inhibitor, right? You have a very limited amount of time. This is acute incident infection during pregnancy. The fetus is at high risk. You would want to add raltegravir or dolutegravir as soon as possible. We know from the VESTED study that there is superior efficacy to the integrase inhibitors, but on average, when you start in the 3rd trimester, it still takes 28 days to be able to get suppressed down to a level less than 200. So time is of the essence. You do not want to wait. A genotype in our setting takes 4 to 5 weeks to come back. She probably will have delivered by then. So clearly the wrong answer. I think, there is some movement in terms of PJP, PCP prophylaxis. We know that for many of our patients in clinic now who we see are suppressed for a very long time and probably don't need PCP prophylaxis if their CD4 is low, if they're virally suppressed. This is not that person. This is a new infection. She's less than 200%, less than 14. I would definitely start Bactrim, TMP, sulfamethoxazole for her. So those are my first thoughts. Back to you, Dr. Agwu.
No, I completely agree. And I think, back in the day when we'd start other things and you're waiting for the viral load, I think the integrated inhibitors really changed the game. You see this rapid decline in the viral load, which is what we need. And this woman with acute seroconversion in pregnancy is so high risk, even if we start to transmit in any way in utero. To know that, I think it may be worthwhile to talk about, when you look at Bactrim, it says contraindicated in pregnancy, right, on certain conditions. And I think it's worth talking about it. This is one of those certain conditions where you would use it because the risk, the benefits outweigh the risk.
Yes. I actually have a question for Ron. Ron, I think there's opt-out testing almost all states for pregnant women so that they know their HIV status very early on in pregnancy. However, not all states have testing for 3rd trimester. The CDC recommends a repeat testing for 3rd trimester for women at risk. But so luckily, the obstetrician gynecologist recognized this as a high-risk patient going back to Zambia, coming back and tested her. But I'm sure there are cases where there's no repeat 3rd trimester testing, and then we find out either the baby is infected or later on the mother is infected. Ron, do you want to comment on this?
And I've actually seen cases like that in the past too, where the mother gets infected during the pregnancy and did not get tested till after she delivered. So the guidelines, the perinatal guidelines recommend reoffering a test during the third trimester to high risk. Now, how do they define high risk? It's similar to when you should be offering routine HIV screening testing or routine HIV testing, in the fact that if you have 1 out of 1,000 or 0.1% positivity rate in your region or the area you're working at, that is considered high enough risk that you should offer third trimester testing. And then, of course, there's other risk factors. So if it's a known IV drug user, known HIV positive sexual partner, something along those lines, then you would also want to offer it or consider the person high risk. So for those of you who don't know me, I'm an adult and pediatric, just like Dr. Agwu, infectious disease specialist. And I've definitely seen cases whenever I used to work in New Orleans of mothers who get infected after the first trimester, but did not, unfortunately, get tested on a timely basis. One thing that this case kind of makes me wonder about whenever we were talking about the PCP prophylaxis, why is her CD4 count so low if she was negative at the first trimester? It makes me wonder if maybe she's during that acute retroviral phase still. It'd be interesting to see what her percentage would be, because if she's in the acute retroviral phase, her CD4 count's going to bounce back up anyway.
Yes.
So she
She
may not
did
need the
back up.
PCP prophylaxis long term. She may need it right away just because you're waiting for your additional results to come back. But it's something I was thinking about during the example you gave.
Yeah. I think that I wanted to show that this is an acute seroconversion, and you can get patients with very low CD4 count, extremely high viral loads. You don't need to wait the 10 years when you're acutely infected. And they can dip very low, and during acute, you might need PJP prophylaxis. Eventually, you will get off it when your CD4 count gets better, but for acute infection, you can meet these kinds of people like they were AIDS, but it's really acute infection. So
Yeah, I think we would probably see in this case, we would probably see a CD4 percentage of higher than 25%. And it's probably just a generalized lymphopenia due to acute HIV infection, most likely.
Yeah, but she fit one of the criteria for starting there. So
Also highlight one of the questions in the comments. Someone's talking about syphilis retesting. And again, in Alabama, we're seeing a lot of third trimester, initial screen negative, third trimester syphilis infection. So coming back from Zambia, I want to highlight that point. She definitely needs to start.
Genital syphilis cases are going higher and higher, more than HIV. So in the interest of time, let's move on to the next case. So the next case is HW, is 21-year-old with perinatal infection. She comes to clinic due to amenorrhea of 10 weeks. Her pregnancy test is positive. She has been exposed to several antiretrovirals since birth. Cumulative HIV resistance testing shows the following mutations: K65R, M184V, and K103. Her CD4 count is 386, and her viral load is below detectable on dolutegravir with darunavir/ritonavir. What would you like to do? 1, send for integrase resistance testing and entry inhibitor resistance testing. 2, absolutely change her current regimen because she has no recommended NRTI backbone in her current regimen. 3, she should continue her antiretroviral therapy during pregnancy because the regimen is effective in suppressing viral replication. And 4, consider adding Moraviroc to her current regimen. We'll poll the audience. What am I supposed to do? I don't think you need this lecture at all. So almost all said, number 3, she should continue her antiretroviral therapy during pregnancy because the regimen is working and is effective in suppressing her viral load. So you are absolutely correct. And maybe can we ask our panelists if they would like to comment on the answer with our very knowledgeable audience?
I will jump in here because this is my group that I love to take care of. I think the biggest point of that is to make sure that you actually dig for cumulative resistance testing. And it looks like that's what they did. So they knew what she had, because there's no way to get, resistance testing on her now unless you can get some DNA and, decide that. So there should be a number 5 there, which is step away from the patient. Sometimes we have to resist the urge to do anything. She's doing great on her regimen. She's tolerating it during pregnancy, and don't touch her. So I think that's the absolute right answer.
Yes. I think
I have great respect for my pediatric ID colleagues, because often when these patients transition to adult clinic, their resistance panel can be very, there can be a lot of resistance accumulated. So even though you don't have tenofovir, 3TC, TDF, FTC options here, I totally agree with what she's on now. We have data for, we have pregnancy safety data. There's no reason to switch. I do think that the discussion with the patient about making sure she's adherent, takes this during pregnancy, continues with her adherence is something important that you'd want to cover. Historically, we always wanted to have that backbone because we wanted something with a good placental transfer rate. So we really wanted the, in the old days, AZT, 3TC to do that. Fortunately, dolutegravir does have a good placental transfer rate. So we're giving some fetal pre-exposure prophylaxis, relying on that pharmacologic property of the drug that the PIs just don't have.
Well, we have 2 PDIDs here. So the question usually is, when the baby's born, what do you give the baby?
I was actually just thinking that would be a good question to come up with.
I'm an obstetrician, so I didn't go into the pediatric side of the guidelines, but while you are here, I think, that would be the second question that people will be asking. And let us ask the experts.
Ron, you can go ahead.
Oh, well, thank you, Allison.
I feel like I talk too much. I'm trying to just hold back.
No, you're totally fine going first. No. Yeah, it would be difficult. You would want to definitely start free drug therapy on the infant until you get your testing back. Mainly because we do know that this is a case, or I'm sorry, this was a fully suppressed patient, right?
Yeah, this mom.
Oh, okay.
So it's fully suppressed.
Sorry, that was my mistake. So then you wouldn't start presumptive HIV infection, but you need to be very cognizant about the treatment. You have to be very cognizant about the fact that although the patient is fully suppressed, it is a patient that does have resistance in their background. Now, they have found that just because a mother has a resistant strain, that because of the decrease in the viral fitness that some of the mutations cause, there is not as much transmission of resistant strains to the infant as, or just because a mom has a resistant strain doesn't necessarily mean that the infant's going to end up with a resistant strain. It does occur, but it doesn't always occur. So that's just something to keep in the back of your mind. I mean, I think the guidelines would just say go with AZT on the infant for right now, since mom was fully suppressed.
Yeah.
Allison, do you agree?
Yeah, no, completely. No, complete concur. I mean, I think, certainly we know that pregnancy can change how people adhere or not, where you can be nauseated, et cetera. So you want to make sure you're asking all those questions and supporting this mom. But assuming that she's suppressed now and she's suppressed during pregnancy, this would be a low risk baby and could get AZT for 4 weeks. I mean, not even the 6 weeks, you can even go as short as 4 weeks. And so, yeah, I completely agree.
If I knew the audience didn't need me to give this lecture, I would have made it more difficult and made her not suppress and then say, what do you want to give the baby? Because then that becomes quite harder to determine. But since I'm talking to a very well-educated audience, I think we should move ahead. TW is 31 years old. She's gravida 2, para 2 with HIV infection for 6 years, acquired from a previous partner. She's currently on dolutegravir, abacavir 3TC, with a CD4 count of 500 and a viral load that is undetectable. She has been adherent to her medications and her plasma viral load has been undetectable for 5 years. She met a new partner who is HIV negative. They are desirous to have a pregnancy. However, her partner is very worried about acquiring HIV and has asked for advice regarding pre-exposure prophylaxis. They both tested negative for any sexually transmitted diseases. Let's poll the audience. Which statement is correct? When partners have different HIV status, sexual intercourse without a condom allows for conception with effectively no risk of sexual transmission to the partner without HIV if the partner with HIV is on ART and has achieved sustained viral suppression. The U equals U. 2, her HIV negative partner absolutely needs to start PrEP before any attempts at conception. 3, HIV perinatal transmission remains high despite ART, and they should consider adoption as the best option. 4, there will never be a need for her partner to start PrEP, even if she becomes non-adherent to her ART, since she has been undetectable for 5 years. Let's poll the audience. Okay. So most people chose number 1, which is really the concept of U equals U, and almost all of you chose it. So I think you know exactly what you're talking about. But let's talk to the audience, to the panel, and see if they would like to discuss, you know, U equals U. It was a very hard concept for many of my patients because for many years that I've been taking care or doing this for 30 years, I've always told them condoms, you know, artificial insemination, sperm washing, ICSI, until I would go blue in the face, and then to suddenly turn around and tell them, just enjoy and have sex. It's like, what? So what about your experience?
I think it's been a very hard thing for clinicians to actually embrace too.
Yeah.
Especially clinicians that have been doing HIV care for a long time. I have to admit, whenever the data first came out, I felt very uncomfortable trying to tell people, you know, we had all this time been telling them yet, ideally one use condoms, and now suddenly telling them that there's no evidence of transmission whenever they have an undetectable viral load that's been sustained. So I think for clinicians, it also was very challenging. And there's probably still clinicians out there that don't feel comfortable saying it.
Well, not this audience.
You know, what I think this forces us to do is to, one, be sex positive and actually to be sex interested, right? And to bring sex into our discussions in a way that allows people to fully talk about their sex, right? Including, you know, even if our married patients or partnered patients, and is that your only partner? And that's okay, because that may be what you're doing. And so there's a comment in the chat, which I think is really good. You know, if you're insisted on PrEP, maybe there is something that's not being said. And so what's your scenario? And maybe you do need PrEP, because when you remember in HPN 052, all the transmissions will link to somebody else, not the partner,
Somebody
right?
else,
So,
yep.
but maybe something else is going on. So I think it's really meeting people where they are. You know, it is a wonderful thing to let people to have sex the way they want to have sex, right? Including without a condom. But you want to make sure that you have all the data to make sure you're advising the couple.
For me, I think there's been really good dissemination to the medical community, certainly within HIV ID providers, but I don't know about patients. Still, I had patients who are coming in, and this is such a wonderful conversation to have where they can take the pressure off themselves to try to figure out some way to get pregnant in this very narrow window for a woman who's already 38, 39 years old, and she's counting down the weeks. And it's wonderful to be able to give this U equals U message. You watch the sort of stress drain from their body, and they just are much more calm about it. And it's a wonderful message. Again, to go back to having the data, to have this data to tell them it is absolutely safe to do this. It's very empowering for patients.
I totally agree. It changed the whole view. I mean, preconception counseling for me used to take an hour, 2 hours, because it was so complex. We had different pamphlets for all different scenarios, as Allison said. Are you really monogamous? Is there any issues that you might want to discuss? I see the couple and then I see them separately also. But today, it's so much easier. It's actually the patients don't believe that this is true. And some of them insist on getting PrEP, and that's fine. As long as they have no contraindications, as long as they follow the follow-ups that are necessary for PrEP, there must, like Allison said, be a reason why one is very worried. And we have to, whether it's a worry, whether it's a scenario where they might really need PrEP, we have to deal with our patients and be able to provide them the care that they would like. So I think
I don't think I would discourage PrEP for the
Yes.
gentleman, because as we mentioned, he could have other risk
Yes.
factors that he's not mentioning there or doesn't feel comfortable mentioning. So I think I would still offer it if the person showed an interest. I think the other thing this case brings up is when we talk about U equals U, we have to remember that U equals U is for sexual transmission.
Mhm.
There still does occur, although it's very low, there still is a chance of perinatal transmission, even whenever a woman's viral load is less than 200. I had a case down in New Orleans where the mother's viral load was 99 at the time of delivery. And she had not been on any antiretrovirals at all during the pregnancy, was newly diagnosed, had a very low viral load, and her child ended up being HIV positive.
It's not zero. Perinatal transmission is not zero. It's less than 1% where we're very lucky, but it's never zero. And there is no, there is some sort of linear, the less your viral load, the less you're likely to transmit, but there's no absolute viral load where you can say you will absolutely not transmit 100%. I don't think any obstetrician has guaranteed anybody that there is no chance at all. Okay, so
I think if I could just add to that, I think, certainly to link back to the conversation yesterday about long-term elite suppressors, et cetera, I do think an elite suppressor who's pregnant should get ART, right? Because of that. So you should just rely on, right? So sort of in that, because I think your patient with the 99, low level or whatever, maybe that she was sort of in that relatively controlled without ART, but absolutely during pregnancy would get ART.
But even the adult and adolescent guidelines, regardless of CD4 count, regardless of viral load,
Right.
you will benefit from starting antiretroviral therapy. So not
I
only
agree.
during pregnancy.
She wasn't elite because she stayed off of medicines after the pregnancy because she didn't get diagnosed till the time of. And she was able to stay off meds, but her infant did end up being positive.
Oh.
Well, we have a few minutes left. Let's go to our last case. And IM is a Liberian woman who just gave birth to a healthy baby girl whose initial HIV testing is negative. IM is on dolutegravir, abacavir, FTC, and her CD4 count is 500 with an undetectable plasma viral load over the past 3 years. She's very adherent to her therapy. She has disclosed her HIV status to her family, but no one in her community knows about her HIV infection. She's firm in her decision to breastfeed her baby despite knowing the current recommendation in the United States not to breastfeed when someone has HIV infection. Let's poll the audience. How can you best help IM? 1, refuse to continue being her doctor because she's going against your advice for her not to breastfeed. 2, if she is to breastfeed, advise her that her baby should continue antiretroviral prophylaxis for the full duration of breastfeeding, even if she has sustained viral suppression on her ART. 3, she should breastfeed exclusively for up to 6 months postpartum, followed by breastfeeding in combination with introduction of complementary foods. And 4, develop a plan for weaning, and rapid weaning over the few days is recommended. Please start your answer. Okay, again, overwhelmingly, the audience chose number 2. The issue is, I think I tricked you a bit there. If she's to breastfeed, advise her that baby would continue antiretroviral prophylaxis for the full duration of breastfeeding, even if she has sustained viral suppression and ART. Now, if the duration of breastfeeding will be 1 year or more, do you really think that the baby should get 1 year of antiretroviral therapy when the mother is fully suppressed? And I would like the panel to be able to discuss this, because this is the, in the guidelines, we said she should breastfeed exclusively for up to 6 months postpartum, followed by breastfeeding in combination with introduction of complementary foods. So we have a difference in opinion here. So I think this is very interesting. This is the first time that we have a difference of opinion. The pediatricians. Let's start with the pediatricians. You think the baby should get antiretroviral prophylaxis the whole duration of breastfeeding, even if it's 1 year?
Yeah, so I think the panel, not the panel, the audience's response, I think reflects where we are. There's a little bit of not so clear. I think that the guidelines definitely do say the 6 months, with the idea that that's probably where you're getting the most benefit for breastfeeding, right? And then where other foods start to come in, et cetera, and then weaning at that point. And usually there is some debate about whether or not the baby continues full ART, going to low severe, and it is a little bit over the place. But I think certainly if this woman is breastfeeding for a year or longer, I don't know that you want to have that baby on ART for that long period of time. And so I would go with 3. Full disclosure, I'm a strong advocate for this at our own institution. We've taken now 11 women through breastfeeding, 11 dyads through breastfeeding with no transmissions, going to 6 months for most women, with one woman who's a little longer than that, not by our design, by her design. And so it's really a strong proponent of this, having several of the women have had babies before, but they were not allowed to breastfeed. I hate that language, but not allowed to breastfeed to when now they are, and the difference in the bonding and just their emotional state, decreased postpartum depression, et cetera. And there have been no transmission. So I think, certainly, we've moved from a period of having angst and saying women cannot. And I think what we've learned from other parts of the world that we can do this, but it would definitely go with.
Ron?
The only thing I would add is, it's the exclusive breastfeeding is one of the really important points, because of that data that came from, I think, Africa, where they showed that if there was a mixture of formula feeding and breastfeeding versus exclusive breastfeeding, there was a higher transmission rate in those who did the 2 approaches. And so I think that's an important point to take home from that message.
Right. And I just think sorry, Jodie, go ahead.
No, Allison, go ahead.
No, I just, this is always brings emotional discussion. I think it's really important. And one of the comments in the chat is about understanding women's motivation for doing that. And why would you want to harm your baby, even if there was like a 1% chance? And for some women, you know, the idea of breastfeeding or not breastfeeding is literally equivalent to being outed and potential safety harm issue for her and her baby. And so understanding what the reasons are, there are the baby reasons or the mom reasons, but then there are actually safety and other reasons. And so making sure we understand that before we weigh in is really critically important.
Okay, 30 seconds for Jodie.
I mean, I still think this is a complicated area. We're all discussing that. I was impressed at Croy to see the data both from Vested and Dolphin 2, seeing those transmissions during breastfeeding in women where they were checking their viral load and they were either suppressed or had very low. 26 was one of the woman's viral loads at the time of testing. So I think in the conversation with the woman about what's possible, telling her that the data still supports in the US not breastfeeding is certainly what I would clearly recommend before all this is happening. You support the woman in her decision. Risk reduction is part of what we do, but I'm nervous. This case makes me nervous.
Yeah, so the recommendation is still not to breastfeed, but if you cannot convince your patient, risk reduction would be. So this is the only question where we, the panelists and I myself chose 3 and most of the people chose 2. So I think that these are my references and I think we are ready for the questions and answers. And we finish on time.
Great, yes, thank you so much. That was a great discussion. There were a couple of questions about whether you could use TAF or why you weren't using TAF as opposed to FDC.
TAF, the data on TAF is not as robust as TDF, but we constantly are changing or updating the guidelines. So don't be very surprised when we change the recommendations as we accumulate more data from studies as well as from the antiretroviral pregnancy registry. It's just that when we did the guidelines 2020, we haven't reached that threshold.
Okay, so we should keep
Keep
looking
an
out to
eye
see.
on the upcoming 2021.
Right. I think worth mentioning, if somebody's already on a TAF-based regimen and doing well, I don't think we're switching those women. So if someone's coming on big TAF and we are leaving
We're
them
not
on.
switching. If you're already on TAF, like I said, when you're on a suppressed regimen, when you come in during pregnancy, we don't change, even if you are not on the recommended regimens. Studies have shown that stopping and then developing side effects or non-adherence increases viral load and increases the risk of perinatal transmission. So, you know, especially when you know, most women know their pregnancy after the first trimester. Very few come in unless they're anticipating it. Usually most women wait for 2 missed periods before they start worrying. So we don't change.
We still have a lot of women on the cobicostat regimens though, and I do take them off the Cobi regimen.
Okay.
So if they're on the Cobi regimen, they don't get to stay on that.
Yeah.
They
Right.
get to go back when they're not pregnant anymore. So that's,
Yes.
that's the care at the end.
So the other
Not
ones are quite-
recommended. We have that.
Right.
It's not recommended. That's different scenario at all because, you know, it's a different problem.
Okay, so that was one of the questions was about COVID. So are there any other antiretrovirals or boosters that you would stop a person that's currently on a suppressive regimen
Well,
other than COVID?
COVID, if they're fully suppressed, some women might choose to continue, but the caveat, I had a slide that you have to do closer plasma viral load monitoring.
Yeah.
Wouldn't be my first choice because I don't want to be worrying and doing plasma viral load every month, you know, and waiting for the patient to come back with so many things that they're doing. I would discuss it with the patient. And actually, Cobi regimens are not the easiest regimens in the world, unless you have resistance, you know.
So there was another question about someone newly diagnosed, a youth newly diagnosed during pregnancy. Would you ever use rilpivirine, TDF, FTC as a 1 pill once a day regimen because they're youth and they'll have better adherence potentially?
for, well, depends on their viral loads and CD4 counts, you know. Would not be my first choice because there are very, very easy regimens that people can tolerate, especially probably when we come to the 2021. We will have more single tablets that are available. So watch out for new recommendations, but it wouldn't be mine.
I think the pharmacokinetics of rilpivirine in the second and third trimester make me nervous. It's incredibly variable, so
Yeah.
I would be reluctant about that choice.
Yeah,
I'll go
no, I-
raltegravir. If I can choose dolutegravir, I'll go raltegravir.
Exactly.
agree on the rilpivirine.
And do you feel that you need to have a long discussion with your patients about dolutegravir and the early data and why we think something different now? Do you start there when you're talking about recommending that as a drug for a pregnant woman?
In the past year, no, actually, but when we were promoting the whole issue, like when we had efavirenz, we frightened everybody away from efavirenz, and then we said, oh, we can use it now. The same happened for dolutegravir, but I think the education for dolutegravir came faster than the efavirenz. Because the data came out more, you know, after in less than a year, the succeeding data came in and we all changed our tune. But with efavirenz, we carried that for years based on primate studies. And so for me, the transition was easier. But, you know, Ron, Jodie, Allison?
No, nothing to add. I mean, I think we went from documenting in everybody's, you know, charts that we'd had conversations, even, you know, women, even though they weren't thinking about becoming pregnant, to, you know, sort of scaling back on that. And I think, you know, the way that played out, I think many people were a little bit suspicious that it wasn't going to be a thing, but you still had to go with the data you had. So it was a little bit of a weird time. But at this point, I'm not having these conversations, and if others are.
Especially when we said that even women attempting to conceive can take dolutegravir. The pregnant women said, I'm not worried. If you know, then I'm not worried to take it during pregnancy if you even recommend it for somebody who's trying to get pregnant.
Okay, and really, I think harking back to this issue of developing HIV during pregnancy, are there recommendations, or should there be recommendations for testing the sexual partners of pregnant women who test negative? This is the first question. And two, when do you use PrEP in pregnancy, or do you use PrEP in pregnancy, and what do you use?
The guidelines actually do have in there a recommendation that sexual partners of a pregnant woman should get tested.
Does that
I think
happen?
even non-pregnant women, anybody who is sexually active with a partner who has HIV, the partner needs to be tested regularly, not just once, but if they are in a partnership where they have different HIV statuses, the HIV negative partner needs to be tested regularly.
So how does it actually happen in clinical practice? Like often, you know, the women may or may not come with their partners to their visits, that sort of thing. Is that something that you all are actually actively doing in your practice?
We are very lucky that in our practice, the STD PrEP clinic is just beside us. So all the partners get free HIV testing in the STD PrEP clinic, but that is not the same everywhere. I'm just very lucky that our setup, we take care of if I have a patient with gonorrhea, the partner goes to the STD clinic, gets treated, don't have to go and look for another doctor and everything. And our state allows me to treat the partner even if the partner is not my patient.
What about in Alabama?
It's the same. So in Birmingham at our 1917 clinic, we have HIV testing available all the time. So we always encourage them to bring their partners. A lot of conversations taking care of women and men with HIV, the partners are part of the I'm taking good care of somebody, but the person can come to them, they can go downstairs. We have multiple ways. I do think the second part of your question is really important. I do think we're not good enough yet. And I'm, of course, from an HIV clinic perspective, at recognizing the women who need PrEP in pregnancy. I think that we still have some more education to do. Maybe Dr. Cu-Uvin, you can talk about this among OBGYNs who say, I'm not sure about assessing risk. I don't know who really needs it. I don't know if their comfort level is there yet.
Yeah, I'm very lucky. Again, I come from a small state. We provide almost all the HIV care, and everybody knows me to just secure chat me and call me or anything, or can I send my patient to you? and so I think, but that is in their mind, that even the fact that they come and talk to me is already a wonderful sign. I don't expect a general OBGYN who, I mean, even us in the HIV field, we follow the science and everything, and we have to constantly update ourselves. So I welcome all referrals. I would rather that they send the patients to me or talk it over before they see their patients. But there are circumstances where PrEP is really very important. I never discourage PrEP. Like Allison said, when somebody's insisting on PrEP, despite you, because you, something else is going on. Maybe they will open up to you later, maybe, or maybe they're just worried well, and you shouldn't deprive them of that.
Great. Well, with that, we're going to have to end this session. Thank you all. This has been a great discussion, and I'll turn it over to Allison to close us out for our general session today.
Thank you very, very much.
Thank you. That was fun.